Think Tank webinar series. This session is titled Practical Tools to Strengthen Diagnosis, Treatment, and Prevention of TB in Children. And this session will be presented by Dr. Karen Dupree, who's from the Desmond Tutu TB Center at Stellenbosch University. And we also have Dr. Sandy Picken. We also will be having Dr. Siponyati, who's from Equity. And then lastly, we will have Dr. Julie Sweetala, who is from the Aurum Institute. I will now hand over to today's speakers.
Thank you very much, Nolwazi. Can you see my screen?
Yes, we can, Karen.
Thank you. Yes, thank you very much for the opportunity to just introduce these great resources and tools that we've developed through funding from the Gates Foundation and within the Child, Adolescent and Maternal TB Task Team. I just want to give a very quick sort of overview perspective. Why do we need to strengthen pediatric TB services? If we look at treatment coverage in adults, it's almost close to 80%. If we look at the 2022 and 2023 data in South Africa. But for children, it's substantially less, with only 65% of children being initiated on treatment of those that has TB. And we really need to strengthen this. So only because at the moment, only one in three children are missing from TB care in South Africa. So as I'm sure most of you are aware, we've updated the guidelines for child and adolescent TB in September 2024. The provinces has really developed plans for cascading and training. There were 3-day provincial training workshops in all the provinces, and all the provinces are in implementation, but just in slightly different phases of implementation at the moment. So as we were updating the guidelines, we really realized that there's a need from frontline healthcare workers to have one document, which is sort of a quick reference guide that incorporates all the important bits in terms of treatment for drug-susceptible TB, drug-resistant TB, and also treatment of TB infection or TPT. And we've also, at the same time, realized that in the new guidelines, we've added ethambutol as a fourth drug for the treatment of all children with TB. And even those with previously only those with severe TB received ethambutol as a fourth drug, now everybody receives ethambutol. And there were quite substantial challenges with dosing and how to appropriately dose the smaller children with an currently available adult formulation. So they were really identified a need for 3 things, right? The quick reference guide that really includes algorithms pertaining to all the current TB guidelines, tools to support administration of ethambutol to the younger kids, and then also caregiver education material to raise awareness, but also support the treatment journey for the family. We then received funding from the Gates Foundation to do this work, and we've, through a competitive process, appointed 2 consultants, Dr. Sandy Picken, who really has years of experience, including development of an online course in the management of child and adolescent TB for the Union. And her role was to develop the quick reference guide. And then Equity Innovations, led by Dr. Siponyati and supported by Dr. Refilje Maamachi, were selected to complete the objectives, given their experience with developing treatment literacy tools for parents and caregivers of children with DRTB. Yes, so obviously this would not have been possible without a whole lot of people. And I'd like to give the thanks up front today rather than at the end. So there were a number of nurses and doctors that reviewed all the tools and provided end-user feedback. The entire task team reviewed the materials, but there was a core group of people that really met every week for a couple of months to get these tools and resources finalized and to support the consultants with some content experts from the task team that contributed with certain sections. Then both Sipu and Sandy were amazing in their dedication and commitment to really develop useful and user-friendly resources. The Secretariat helped us tremendously with organization, and then the Gates Foundation that provided the funding to make this possible. So on that high note, I'm handing over to Sandy, who will explain the quick reference guide or take you on an overview of the quick reference guide. Thereafter, Sipu will show you the resources that they developed, and then Julie will take us on a practical, interactive journey through how to use these resources.
Great. Thanks, Karen. I'm up next. Hi, everybody. I'm Dr. Sandy Picken. Thanks for the introduction, Karen. Just checking that everybody can see my screen clearly.
Yes, thank you, Sandy.
Okay, that's great. Right, I'm here to introduce the quick reference guide. I'm very excited to share this. So essentially, this is a quick reference guide for frontline healthcare workers on the prevention, diagnosis, and treatment of both drug-susceptible TB and rifampicin-resistant TB. It is aimed at children and young adolescent aged less than 15 in a South African context. As Karen said, it draws out the key elements from these three main guidelines, and it also draws on some of the rifampicin-resistant TB preventive treatment recommendations from the 2019 RR guidelines. So this quick reference tool is composed of 8 sections, and I'm going to take you through them briefly just to show you what's included. So essentially, Section 1, this first section is centered around this main TB treatment decision algorithm, which comes straight from the full PEDS TB guideline shown here. This algorithm encompasses a full TB consultation, starting right from the beginning with screening children and ending with either treating for TB infection or TB disease or following up the children. So essentially, Section 1 of this quick reference tool has been designed to provide all the how-to tools for each step of this algorithm to ensure that the healthcare worker is equipped to competently navigate through this algorithm without any uncertainties. So the information in the quick reference guide is presented in discrete little blocks as explanations or definitions or instructions that are relevant to each step of this algorithm. So let me show you a little bit more about how this is done in detail. So we've broken down the algorithm into smaller, manageable steps using a red dotted line to keep the user orientated. Each page deals with a different aspect of the algorithm, but you'll notice we follow the patient pathway according to the flow of this algorithm. So from top to bottom, like this. So these are what the pages from the guideline look like. You'll notice that in the top right-hand corner, the algorithm is there showing you what part of the algorithm the page is focused on. As I mentioned before, it goes from top to bottom according to the patient pathway. Each little block on that page provides directions for how to conduct or perform the task that the algorithm is asking for. So, for example, in the top of the algorithm, where the little gray box of the algorithm instructs the user to screen for TB symptoms and TB exposure in all children at every healthcare encounter, it'll have a corresponding little how-to box, which will tell you how to screen for TB symptoms or how to screen for a significant TB exposure. You'll see in the second blue box here, you'll see the algorithms asking you to screen for signs and symptoms of TB, which seems simple enough until you get to something that might need a bit more information, such as growth faltering here. And so there'll be a corresponding box on how to, just to remind you what's considered growth faltering and so on. So the pages have also got relevant headings that follow the algorithm patient pathway, and you can see here, these are some of the pages. They go from screening for TB infection and TB disease to then identifying danger signs and symptoms. You'll notice that there has been some familiar IMCI content that's been integrated there. And then moves on to identifying who needs TB investigation, further TB investigation, and when, what those investigations look like, how to interpret the results and to diagnose TB, how to initiate TB treatment, a reminder to notify for TB disease and how to do that, a short aid for what to explain to the patient and their family, and monitoring and follow-up. And there's a similar set of pages that follow the right-hand side of the algorithm as well. At the end of section 1 is a condensed quick reference summary of all the consultation steps with some useful page links to help navigate. And these essentially summarize all the consultation steps. So it's steps 1 to 7, and they include screening, assessing and interpreting, diagnosing, initiating treatment for the various relevant forms of TB, whether it's TB infections or TPT, or whether it's treating TB disease, whether that's drug susceptible or drug resistant. There's reminders to check for medication interactions, a reminder to notify, some prompts to educate and check the understanding of the patient and their caregiver, and follow up as well. So section 2 is dedicated to TB preventive treatment. It's been designed to support the healthcare worker to choose the appropriate regimens according to the child's weight and, where relevant, the sensitivity profiles of the contact or the index source contact patient. It also includes the information on DS and RR-TB infection and all the relevant dosing tables. Section 3 is dedicated to the treatment side of drug-sensitive TB. It starts with a step-by-step one-pager guide on how to determine if a child is eligible for the shortened 4-month TB regimen, and it obviously includes the familiar drug-sensitive TB dosing tables. Section 4 outlines the treatment of rifampicin-resistant TB in kids, including how to initiate the treatment, and a useful scheduling table with baseline and follow-up observations and tests. It includes obviously the rifampicin-resistant TB drug dosing charts. Section 5 and 6 are quite short, just 1 pages. Section 5 dealing with rifampicin drug interactions, and section 6 outlining the management of common treatment side effects and reminders around how to report adverse drug reactions. And then section 7 is quite a comprehensive section about how-tos. It's got a step-by-step illustrated instructions, starting with how to review a pediatric chest X-ray for TB, and these come out of the Union's Diagnostic Chest X-ray Atlas. It's then followed by all the procedures, which have, again, illustrations for each step to guide healthcare workers on how to do these procedures. So how to get a good sputum sample, how to induce a sputum, how to do a gastric washing, how to conduct a urinary lamb test and interpret it, how to do a TB skin test. And there's a little section there on tips for collecting stool samples for caregivers as well. And then lastly, section 8, which Sipa was going to take us through, is including all those materials for patient education and support. And there are dosing aids, particularly for the ethambutol part, some awesome posters, and some patient information leaflet as well. So those are included at the back of the guide for quick reference. And essentially, that is all from my side. Thanks.
Thank you very much, Sandy. Yeah, that is excellent. I'm thinking, Nolwazi, do you want us to do questions maybe at the end? I think that might be
that's preferred.
Okay, great. So let's then move on to Sipa. But thank you very much, Sandy. Awesome, very exciting.
Okay, thank you, Sandy, and I think I'm just going to dive right into it. So we developed these posters, and I'll explain a little bit how, we hope for them to be utilized. But really, so the first one is really just explaining what tuberculosis is. The primary audience here really is your caregivers, but also works for clinicians as a guide on how to do health education. And we're really hoping that this helps to address some of the anxiety, some of our healthcare workers have around diagnosing and managing pediatric TB. So, I mean, the idea is really that most of this material should be at, grade 6 or lower reading level. Try to make it, kind of as illustrative as possible. So this is, what is TB? This is also what are the signs and symptoms of TB. I think you can see that, again, diagnosing TB in children, is, it's a puzzle, right? So you just need for caregivers to kind of understand that we have to go through several steps in order to diagnose TB in children. So I think this was meant to kind of do that, because a parent might wonder, you've already collected a sputum. Why are you doing an X-ray? Why are you collecting a stool sample? Why are you collecting a urine sample? I think the idea is just to say, in order to solve the puzzle, you do need to kind of go through all these different steps. So this could be a poster, but because it's it's iterative, we thought, again, if you could have this as a flip chart in the nurse's station, in the healthcare worker station, so that, again, she can kind of take the patient through, what TB is, what the signs and symptoms are, in an illustrative way, as well as, what kind of diagnostic procedures their child will be subjected to. So let me just go. And then I think the next one, which I think we spent quite a lot of time trying to develop here, is really the issue of including ethambutol in the treatment for pediatric TB. We don't have it as a fixed dose combination yet. So I think the idea is, first of all, parents do need to kind of understand treatment duration, what kind of treatment they'll be taking. So again, this is just kind of an illustration of what the tablets look like and what processes the child will go through as they are being managed for TB. I think the place where we spent a little bit of time is really trying to explain, again, how do we go about crushing and mixing the different medications for the child. It's quite a complex process, but a process that needs to be learned. So it's really kind of the step-by-step guide on, how do you crush the ethambutol tablet? You put it into water, you draw, you mix, you measure the right dose, and then you give to the child and you throw away the additional mixture. So this would have to be a guided process. I think you will see that we also have a table here, that just kind of shows, again, the different weight bands and what dosages that they should take. This, again, is targeted primarily to your healthcare worker as she educates the patient on, for your, let's say your 4.5 kilogram child, this is where they are. This is how you crush and mix and give the patient doses as well. We've also created just a separate a separate pamphlet like this, which will also be given to the pharmacist so that as they dispense, they should also be in a position to explain to the caregiver how exactly to administer the medication. So I think we do appreciate that, it is quite complex, but, we've been doing this for quite a while for children without any IEC material to support them. So we really hope this will make, them managing children a little bit easier. Let me see. So that's that. And then the last one, and this is really the one that's, it's a guide for caregivers, but we were also thinking that the same guide could also be given to community healthcare workers as they do outreach, because they'll invariably come across children that are on TB treatment. This will help them again to provide very clear and accurate information around TB management. So it would be great if we could actually print this for all children, because as you can see on the side, we've actually put, kind of the different weights. So at least we can then articulate fairly clearly in terms of how many mils does a child take for RHZ and how many for ethambutol, just again as an additional reminder to them, as they are taking the medication. And so, there's a different words of encouragement. I think we tried again to try and summarize some of the information that they will have already received from the clinic. So again, you can see something that looks familiar here. What is TB? What are the TB symptoms? When medication is given, eating healthy, and again, kind of a side effects and, kind of the red flags, the way when a patient needs to go immediately to the hospital for additional care. So really this, funding permitted would be really nice to, one, translate into the different local languages, but also to make sure that our community healthcare workers have access to it. Additionally, our clients and caregivers also have access to this information, just so that they can utilize it to remind themselves of the treatment. Yeah, I think, so that's it. I think those are the tools that we've developed to support what I think is a very, simple guideline and, to support the caregiver pamphlet. Thank you.
Thank you very much, Sipu, for taking us through those. I'm very excited. I know lots of people are super excited to see it and be able to use it for implementing. So, and all of those will be available. I saw there was a question around translation. So maybe before I hand over to Julie, just to say, we are actively looking for funding to translate in all languages. Yeah, but so it's not available yet in all official languages, but that would be the idea, to work towards that. At the moment, afterwards, we'll share with you the links. It will all be available to download on the think tank website as well. Okay, so I'm handing over to Julie to take you through a practical session.
Thanks, Corinne. So yeah, I've got the fun part. We're actually going to put these things into use and see how easy it would actually be if you're looking after a patient. But just before I start, I just want to say a huge thank you to Sandy and Sipo and the equity team. I think what was displayed today doesn't show you the number of revisions that they were asked to do and the countless meetings that were had, and they were just incredible to work with. And I think that we've got these incredible tools as a result now. So we really hope that everybody on the call will assist us in getting them to patients and healthcare workers, which is where they're needed. So I'm going to start straight away with some case studies, and hopefully we'll cover most of the guidelines and the quick reference guides as we go. So I think the important thing to remember is the heart of the new guidelines is this treatment decision algorithm. And I'm assuming that everybody on this call has the abilities to support other districts. But I think that the important part to remember here is this is a decision algorithm. It's not necessarily a definitive diagnosis algorithm. The point here is that we want to make safe decisions for patients at any level of care. So what you'd have available to you if you're working in a pediatric ICU would be very different to what you're doing, what you have available if you're at an outreach clinic. But the point of this is to use what you have got to make the smartest decision that's child-friendly, that's safe, that doesn't miss other diagnoses, and as best as possible not to overdiagnose TB as well. So this is the heart of the guideline, and all of the case studies will be going through this step by step. So our first patient is a 4-year-old girl who is HIV unexposed, and she presents to the clinic with 6 days of coughing and fever, and the nurse takes her temperature and sees that she again has a temperature of 37.8. She has got some crypts on her left side of her chest, but she's otherwise stable. She has no features of respiratory distress, and she's quite miserable. She's clearly not having the best day of her life, but she cooperates, and she's fully awake and alert and is able to eat. So the mother also tells you to ask her, and she says that there's nobody that she's aware of that has got TB. So if we summarize that, we've basically got a 4-year-old child who's unexposed, but we've all been fallen for that many, many, many times. I've currently got a 10-year-old child in my ward who's newly diagnosed with HIV and her mother is negative. So unexposed doesn't mean anything. You always test again. This child doesn't have TB contact. She's got 6 days of coughing and fever, and she sort of seems to be growing pretty well. I'm not sure if you're seeing all the dots or just the one. On my screen, I'm only seeing the one, but she's got a good growth curve, and she's got some crepitations, but no other really concerning clinical features. So where would you go next? If we use the quick reference guide or the decision algorithm, we've got to decide, does this child, how far does she go down the TB decision algorithm? So we start everybody up at the top, and there are 2 ways that you can get from the gray area up at the top to the blue area that's next. And you get there by either screening positive for TB or being part of a very high risk group. So the high-risk groups, there are 2 reasons why they're special. The one is because they have a high risk of having TB that could look like the other problem. It could look a bit like HIV. It could look a bit like malnutrition because this child's not growing, maybe has some lymph nodes. So it's either because there could be overlap, because we know that these are children at very high risk of actually getting TB and moving on to getting TB disease if they're infected, or because they're a child who, if we get it wrong, have a very high chance of progressing to quite severe disease. So in this case, our little girl here she has got a cough, and it's only for 6 days. But I'm highlighting here that in the pediatric screening, a cough of any duration counts as a positive screen. In the adult guidelines, it would be a child who's coughing for an adult who's coughing for more than 2 weeks that would screen positive. In this little girl's case, she sort of had this weight that was sort of staying similar, but she was kind of growing. So I've given her a question mark there of if she's actually having failure to thrive or not. So if on either the high risk or the screening criteria, you pass, and you are then moved over to the blue area, we would need to then decide if you have any features that really look a lot like TB. So the features we'd be looking for in a child are, is this child wheezing? Has this child got a cough? And acute is acceptable, but chronic really makes us suspect TB. Is there an unexplained fever? So obviously that's different if this child has got confirmed tonsillitis or some other reason that you're sure that they've got a fever. Night sweats we do ask about, but that's not actually a very common presentation in children. Failure to thrive, which I think is the most under-recognized feature of TB, and especially if it's failure to that hasn't responded to something that you've already tried. So you've dewormed the child, you've checked that the sort of dietary intake is acceptable for that child, and the child is still not gaining weight. So remember, kids are designed to gain weight. So losing weight means that they really are doing very, very badly. Not gaining enough weight is considered failure to thrive. Lymph nodes, especially if they're in the cervical area, the clue is that they are non-tender lymph nodes that have sort of been there for a little while and usually are more than 1 centimeter. And you might have one rubbery lymph node that you can move around, or a feeling that's a little bit like one of those Aero chocolates. where they feel matted, and you can kind of feel like a couple of the lymph nodes are all together. And often the parents can't quite tell you what the problem is. They just say that this child is not right, or she's not well, or they're not themselves. And I think that's probably the most common feature I've seen, where a caregiver has said something's just not okay with my child. But you can see using this algorithm, so you've gone on from the gray section, then you go onto the blue section. And I think that you would agree in the patient that we've discussed that she does have features that are typical of pulmonary TB. So once we've moved from pulmonary TB, we need to decide, does this child have any danger signs that would make her immediately need to be referred or stabilized? In other words, we're putting the decision about TB aside while we're saving the life. So is this a child who's got who's got a decreased level of consciousness, or is very dehydrated, or is really having significant respiratory distress? And what those danger signs are mentioned elsewhere in the guidelines. But in our little patient that we described, we said, okay, she's not too bad. She seems to be sick, but there's nothing that's really dangerous. If you look at the third bar that's blue, we give another option for kids that can be fast-tracked down. And those are kids who are under 2 years old, kids who are living with HIV, or kids who have got severe acute malnutrition. So you'll see that there is some overlap. Those were kids who also got onto the blue section as a fast track. But because those three groups are so likely to get very sick if we miss TB, they have to immediately go down to the yellow section. The girl we described was a 4-year-old. She didn't have any danger signs, but she did have typical TB signs. So she passes that block for the severe risk factors. And we asked, does this child have anything that's lasted for more than 2 weeks? In her case, she's got no danger features. She's got no high risk features. She hasn't had features for more than 2 weeks. So in her case, we would probably treat the most likely condition, and we'd want to follow up in 1 to 2 weeks. So I hope that all of you agree that in this case, she probably has a pneumonia, and she's appropriately started on 5 days of amoxicillin. And as the cough improves, that's great, but you were a very astute clinician and you made sure to bring her back. And when she comes back, the mom says that she got better on the coughing, but she's still not really quite herself. And the mom thinks that she doesn't have a thermometer, but she feels that she has been warm to touch twice since the last time that you saw her. So now she's reached the point where she has got prolonged symptoms, because now this has been almost 2 weeks, and she's also failed treatment for the most likely cause. So now she's going to go down the same route as she would if she was fast-tracked by being under 2 years old, or having HIV, or having severe acute malnutrition. So in this yellow block, we now recommend some sort of investigations to exclude TB. So the two main sections we think about are radiological investigations, and then anything else that we can do in that setting to exclude TB. So we'd love to take a diagnostic sample, and Sandy's given us really great guidelines on how to take which sample on which child. We would consider a TB NAT test if it's a child who's HIV positive and meets the criteria. We would consider a Mantoux test if it's a child who's young enough and doesn't have a known contact. And we would sort of basically do whatever we have available. If they've got a big lymph node, maybe you'd like to take an FNA from that lymph node, and we'd see how we go. So choosing the right investigation, this seems very, very intimidating to people, and I think the majority of the queries I get are based on the diagnosis, not based on treatment. But when you summarize it simply and know who qualifies for which test, it's actually not that complicated. So children who deserve a TB skin test are those who don't have a known contact, because the TB skin test that's positive only tells us that they have TB infection or disease. It doesn't differentiate. So it doesn't really add much information if you already know about the contact, and if they're under 5 years old. A urine lamb test is only for patients who are HIV positive and have severe HIV disease, or AHD, either because they are so sick that they need hospitalization, or because their CD4 count is so low that we classify them as very high risk. Chest X-ray is incredibly helpful, but that's not always available. And in some situations, something like an abdominal ultrasound or a spine X-ray, or even a joint X-ray might be more appropriate. than a chest X-ray, depending on the symptoms. And of course, a CT brain if you're concerned about TB meningitis. Then what are we going to send to the lab? First prize is always going to be sputum. So if it's a child who's old enough and with a little bit of coercion, you can get that child to give you a sputum, that would be the first prize. Second prize would be an induced sputum. And I'm being bold to say that that would be better than a gastric aspirate because it's much less unpleasant for the child to have an induced sputum. And it also is a little bit easier for healthcare workers because a lot of people don't like waiting the 4 hours that they need to pass a gastric, an NG tube for a gastric aspirate. We now have stool as an option for the samples that we would take for children. But unfortunately, this is not going to be the miracle that we all hoped it would be. It's not anywhere as close in sensitivity as one of the true pulmonary specimens would be. So stool is a last case resort. A fine needle aspirate or any other sample. Sometimes it's a biopsy, sometimes it's a bit of pus or something like that. And you can send that off to the lab and ask for one of 3 things. So the lab can do one of 3 things for you. They can either look for a little bit of DNA, they can try and see if they can grow TB, and of course we sometimes need resistance testing. But please note that in the new guidelines we don't recommend microscopy for children. Firstly, because we know that children are not the spreaders of TB, so they're not going to infect anybody else, and we don't need to use that as a monitor, but also that it's wasting quite precious specimen that was often quite hard to get, and it's almost always negative. There's almost as much chance that it's a false positive as getting a true microscopy that's from a child. So we don't recommend that at all. And then also, obviously, depending on the child, we look at what other relevant investigations might affect your management. So HIV is always a good idea. If it's a child who's got TB meningitis, you might want to do a lumbar puncture. If it's a child with the fusion, help you as well. So in this situation, we've got a 4-year-old. She doesn't have an own contact, so TST is a good idea for her. Chest X-ray would be a fantastic idea for her. She's able to give us an induced sputum that gets sent off for a night test as well as a culture. And as we mentioned, we always do an HIV, which in her case was negative. So this is the chest X-ray that we have from this little girl. And I'm sure that you can see if you look at her mediastinum, it's quite an underpenetrated X-ray, but that very wide mediastinum is quite obvious. And then the classical picture of a donut sign on the lateral that gives the diagnosis away. So remember, it's not just the X-ray that we're looking at in this child. This child has come all the way down the algorithm to get to the X-ray point. So she's got chronic symptoms that look like TB and a positive chest X-ray. And that should be enough to make the decision to start her on TB treatment. So in this case, she did have a Mantoux reaction that was 11 millimeters. And for a child who's HIV negative, that is a positive result. She wasn't eligible for a urine lamb test, so that wasn't done. The chest X-ray showed hyalurolymphadenopathy. The nurse was not able to get a gastric aspirate or an induced sputum from her, so she said she's not going to do that, and she would rather send the child to a hospital. But the hospital said no, and then she's HIV negative. So with what we have got, what decision can we make? In this case, she's got 2 good features plus chronic symptoms, and that's enough to start her on TB treatment. And you'll see that that's exactly where the algorithm takes us. So if there's something on the chest X-ray or any of your results have pushed you in the direction towards treatment, we would say, please do treat. Of course, we want you to follow up any results to check for resistance testing if there were any taken. And we always want you to notify children who were started on TB treatment. And then, you would use CPOS tools to explain to the caregiver exactly how to give the medication. The exact doses and so on are all in the guidelines as well as in the quick reference guide. So how you would choose your regimen. Firstly, you need to know the susceptibility. In this case, we didn't get a sample from the child. We also have no known source case, so we're going to have to make a guess. And if you're unsure, you would usually start off with drug-susceptible TB treatment. We also need to decide, does this child have pulmonary TB or extrapulmonary TB or TBM or miliary TB? Because the regimens do vary a little bit. Then we need to decide if there are any features of severity, because if you have any features of severity, you would not be eligible for a short course. So there are the features of severity are mentioned in the guidelines. Other things that you might want to consider is if this child's previously had any TB treatment, has this child had TPT that failed, and was there any other medication that might make you opt for one medication rather than another? And unfortunately, we also have to be practical and say you have to pick a regimen that's actually available at your diagnosing facility, as well as where the child will be following up. So in her case, we don't know her susceptibility. We were pretty convinced that this was pulmonary TB based on the symptoms and the chest x-ray. She doesn't have any features of severity, and in her case, she's pretty uncomplicated, so she doesn't need anything special. Now we need to decide if she qualifies for a short course. So the short course, there are two ways that there are two different algorithms that we use. And the one is if there is a chest x-ray available. And if there is a chest x-ray available, we're quite comfortable that we could assess if the child has got any features of severity, and that we can look for if there are any cavities. So we can be a little bit more lenient with you if you have got a chest x-ray available. And the age category there is you need to be between 3 months and 16 years of age. You need to have drug susceptible TB, or at least presumed drug susceptible, and maybe cervical lymph nodes, and that's pretty much all. So you can't have extrapulmonary TB. This has to be your first episode. You can't have any danger signs at the beginning when you present. You can't have severe acute malnutrition. And if you have HIV, you have to be a STAR patient. So you have to be a patient who's been on HIV drugs for more than 3 months, and you have to have a viral load that's under 1,000. And you can't have anything that suggests that you've got a pulmonary occlusion of your bronchus. So you can't have unilateral or persistent wheezing. Then we look at your X-ray. I'm not going to go through those just for the sake of time, but there's certain features where if those are present, you may not qualify for a short course. But if they're not there, and in this case they weren't, this child now qualifies to get a 4-month course instead of a 6-month course of treatment. So you'll remember these video games. You don't get to jump straight from the decision, the first poll, all the way to the prize. Unfortunately, you need to meet criteria 3 times to get that 4-month treatment. So you need to meet the baseline criteria that we've mentioned. You also need to meet the criteria at month 1, and that is that all of the signs and symptoms that you presented with are better. They don't have to be perfect, but they have to be better. At 4 months, somebody gets to decide again. All of the signs and symptoms now to be completely resolved. You need to be gaining weight in an appropriate way, and they can then agree with the people at initiation and at 1 month to discontinue the treatment at 4 months. So I think the important thing here is often you'll have a doctor making the decision at initiation that this child qualifies for short course, and you might have a junior member of the team, a nurse at the clinic, who gets to change her mind about that decision and say, no, I'm not happy about 1 month, I'm not happy about 4 months, this child is now going to get a 6-month regimen instead. So you can always upgrade, but you cannot downgrade the decision that was made at the baseline. So in her case, she qualifies for 4 months, and as long as she does what she's supposed to do at 1 month and 4 months, we will discontinue her treatment. So what's changed in the new guidelines? Ethambutol is back for everybody. And we're not going to go into the details of why. We can cover that in the Q&A afterwards. But basically, the short course is going to be 4 drugs for 2 months, and then 2 drugs as a continuation phase. So it's very similar to the old 6-month course, except we just chopped off the last 2 months of the continuation phase. And all of the dosing charts are available in the guidelines. So what are we going to do for this child? Firstly, we've got to diagnose her, and we have diagnosed her. We have to notify her as having clinically diagnosed pulmonary TB. We can't call it confirmed TB unless the lab has confirmed it. So that would only be if there's not microscopy or culture that's positive. But we also know that 4-year-olds don't walk around the world getting TB out of nowhere. So we have to go and try and find who was the adult or adolescent that gave her TB. So we do reverse contact tracing, starting at the home, or if there was any other setting that we think would be relevant. We need to write a note in her Road to Health card, and we would like to plot her weight so that the next person knows where we're starting from, and also about our decision that we think at this point that she qualifies for just 4 months of treatment. We're going to explain the medication to the caregiver and what to expect, what side effects, and make a good follow-up or linkage plan. I've recently been involved with a child who was diagnosed with TB at a hospital. A plan was made for him to follow up, went to the clinic, and somewhere in the notes it was missed that he was actually supposed to be there for TB treatments. So he was readmitted a month later, very sick from TB, just because the final linkage wasn't done correctly. So that is really a very important step. So this is the interpretation that we spoke about. In Sibongile's case, it was nice and easy because she had a chest x-ray that really let us think it was TB, and she also had a positive TB skin test. But if that wasn't the case, sometimes you've got a situation where there isn't a chest x-ray that's available, or the chest x-ray is a bit neither here nor there, or the diagnostic tests are unavailable, or also give you sort of ambiguous results. And you can see if that had been the case, we give you a chance to earn your TB treatments again. We say, look, you've come all this way down this algorithm. Did you have a TB contact? Because if you've come all the way down here and the diagnostics have been a bit iffy and you had a TB contact, we're probably going to start you just to err on the side of caution. So in that case, we would start a child on TB treatments. If they didn't have a TB contact, you still feel like, well, you've come all the way down this algorithm. Is there anything about this child that really, really makes you think this looks like TB? These are really typical nodes, even though she didn't qualify on any of the other things, or this really, really looks like, a clinical story that makes you think that the child has got TB. If your gut feel just says yes, we would say, fine, go ahead and treat for TB. And we rather would overtreat or undertreat. If you say no, then you could consider other diagnoses. Could this just be the child's anemic? Could this be that the child's got malaria? Could this be that the child's got HIV and it's just HIV related? We'd consider other diagnoses, treat those, but follow-up is actually part of diagnosis, because a child who's got TB is going to show you that he's got TB at the next visit or the one after that. So if you're unsure, allowing the child to follow up, as long as that's a proper follow-up plan with good notes, ideally with the same clinician, that is a feasible option. But the one thing, if you really, really, really aren't sure, there is a part of the algorithm that allows us a clinical score. So this is based on a WHO-approved algorithm where we allow you to score certain features about the child. And if the score is above 11, then we say, you know what, maybe go ahead and treat the child. So this is a very blunt instrument. This is something that would be very helpful if you're somewhere at outreach, or you really don't have lots of diagnostics and you're unsure. I don't think it's ideal. And you'll see at the top, we really say that a good clinical acumen and a clinician's decision is probably more helpful than a score sheet. And you'll also see that in this case, in Sibongile's case, she actually wouldn't have qualified for TB treatment if we'd only used the scoring. So the scoring is there to help, but it's absolutely not a replacement for good clinical acumen and follow-up, and sometimes erring on the side of over-treating rather than under-treating. So you do things properly and you do some reverse tracing, and you go home and you find out that Sibongile's mom, Linda, is also found to have TB. So she was able to give you a sputum, and she's got a RIF susceptible TB on her sample, and she is started on treatment, but you're not the adult doctor, so the adult doctors are managing Linda. But she's a little bit worried because she gave birth to a baby just a week before. And she also lives with an 11-year-old child and her 2-year-old niece. So there are actually quite a couple of kids in the setting that you're going to need to sort out. So what are you going to do for each of these kids? So the first thing we need to do is look at the 2 kids who are potentially exposed to Linda. So just to be very clear, Sibongile was the 4-year-old who was the index case. She was the first person who alerted you to TB in the setting, but she is not the source case. So we know that an adult or adolescent would have been the source case here. So you look at Angel, who's 3 years old, and you can see she plots beautifully. So she's asymptomatic and she looks fantastic. Sipho is 11 and he no longer has his road to health card, but he weighs 32 kilos and he's got a normal BMI. So if we use the same reasoning, we have to screen both of those children, and we see that both of them screen negative, and both of them have HIV tests that are negative. So they don't move from the gray area down to the blue area because they don't screen positive. So if you don't get into the blue area at all, you exit the door on the right, and the door on the right says, do you need TPT on your way out? And in this case, both of these children qualify for TPT. So because Angel is under 25 kilos, We don't actually care about her age. South African guidelines only really care about the weight. So she's under 25 kilos. She's got no symptoms. So she does not need any sample. She doesn't need to give a gastric aspirate. She doesn't need to be referred to the hospital. We don't want to do a Mantoux test on her because we know it's not going to give us any additional information. She's asymptomatic. She's problem-free. We would just start her on the TPT. An X-ray would be lovely if it's available, but that's not always possible wherever you are. In Sipho's case, he's 11 years old. He's more than 25 kilos, so we manage him as we would an adult, and we ask all adults to provide sputum regardless of their symptoms. And that's because we are more aware now of how many people are walking around with asymptomatic or incipient TB. So we would ask Sipho for a sputum, and we would ask both of them to have X-rays if they can. In Angel's case, there's no chest X-ray available at the clinic. In Sipho's case, he has a chest X-ray done in private, but it's unremarkable, and he's unfortunately not able to give you a sputum. So again, we've got 2 kids who weren't able to give us samples, but we would still start them on TPT. So how would you choose your regimen? Firstly, you would go based on the known susceptibility. In this case, we know that they have a drug-susceptible contact. Depending on their weight, we would put them into either the adult or child algorithm. The HIV status and which drugs they are on could affect which regimen you would choose, and which formulations are available where you are. So under 25 kilos and HIV negative, you would get 3RH. Sipho is lucky because he's over 25. He qualifies for 3 HP. So he only needs to get once weekly treatment. And obviously, if the source case had been RIF resistant, we would have given the children both 6 months of levofloxacin. And if she was INH resistant, we would have given 4 months of rifampicin. So now what do we do for Gugu, who's this little baby whose mom had TB, it seems like during the whole pregnancy? Gugu got a BCG when she was born, and Linda was negative at delivery. So we know that Gugu is negative. Now, what do we do for her? Because we know she's going to have ongoing exposure. She's also had exposure before she was even born. But the tricky part now is that she's had a BCG. So the concern with the BCG and TPT is that BCG is a live vaccine that's also a mycobacterium, and if we give TPT, the risk is that we kill the M. bovis and we don't get the response. But first thing we need to do for this baby is we need to decide, was this true exposure? So if she has had a mom who hasn't been on treatment for 2 months, which is true in this case, we would consider that exposure. If the mom has been on treatment for more than 2 months, but is clinically doing poorly, still has a positive smear at delivery, or is diagnosed with TB soon after the delivery, this would count as exposure. So I often get the question, but why are we not worried about the baby who had, whose mom's only been on treatment for 3 months or 4 months? And we know that they were exposed, but we also know that they've been exposed to the drugs in utero. So we're assuming that the baby has had enough drug exposure to kill any TB that's present. Once we've decided that this child is truly exposed, we then need to decide if the child has any features of congenital TB. And you can see we've got a nice guideline of exactly what investigations to do. But I think the thing we want to highlight here is all babies, even if you're aware of their TB exposure, we want to simplify decisions at the maternity unit. So all babies, regardless of HIV or TB status or exposure, get a BCG unless they are unwell. And then we can give them their TPT or treatment, and we would rather repeat the BCG afterwards. So in this case, you can see that this child meets the exposure criteria, but she doesn't meet any features of perinatal TB. Mom, we know, is drug susceptible, so she would qualify for her 6 months of TPT, and she will get a repeat BCG at the end of that treatment. So the new BCG guidelines, another big change is, firstly, that we're giving it to everybody. Secondly, that we are giving a catch-up after your TPT or TB treatment if you start that treatment shortly after birth. But we also allow for a catch-up vaccine for any children under the age of 10 who didn't previously get a BCG. So that's a little bit different. We previously said that that was only up to the age of 1. So now we're a lot more generous. So then there's another little girl. So you're the community service doctor who's working at a regional hospital, and the nurse refers quite a sick child to you. She's 4 years and 9 months old, and you do a mid-upper arm circumference for her, and it's 110 millimeters. you don't have previous weights, but you plot her and she's plotting on the -3 Z score. She's had a week of diarrhea, no coughing or fever, and she moved to live with the grandmother 2 years ago because of the mother's work commitments. And the grand says she's always been quite a quiet, timid child and just doesn't eat so nicely, but today she feels that the appetite's even worse than usual. The grand doesn't know of any other previous medical histories, and the mother has the road to health card, so you don't know what her previous weights were. On examination, she's got lots of tiny little lymph nodes. She's pale, and she just really looks quite pup and not very well. But she's adequately hydrated, and she is quite wasted. She sleeps most of the time, but she can answer your questions sensibly and hasn't got any neck stiffness or focal signs, and she can eat a little bit. Her chest is fine, but you pick up that she's got a 4-centimeter liver and no other clinical features that worry you. So because she's quite sick, you do a glucose on her, and that's fine, and her other vital signs are all within normal limits. And your senior doctor will only be back on Monday. So if you could only do one test for this child, what would this be? I really hope you would say that you would do an HIV test on this child, because she's got features of a very long-term illness. There might be new things on top of that, but knowing what her HIV status is really going to help you to decide which route to go next. And unfortunately, her HIV test is positive. So all of the other lab tests are sent because you know that you're going to want to start this child on ARVs, and they will be available on Monday. So what should you do next for this child? Because on top of her HIV, she seems pretty unwell. So again, we'll use the decision algorithm. And in this case, you can see that this child qualifies as a positive screen because she's fatigued and not quite herself. She's also had weight loss or failure to thrive. We don't know what her previous weight was, but if your first time that we're plotting you and you're on the -3, you qualify as having failure to thrive. So she actually qualifies to move down to the blue section also because she's high risk, because she's got severe acute malnutrition as well as having a newly diagnosed HIV status. Then we need to decide if she's got typical features of TB. In her case, she does. She's got this failure to thrive. She's got lethargy and reduced playfulness, even though she's not actually coughing or having any fever. She doesn't get to exit the door on the right because she has been newly diagnosed with HIV and SAM, so she gets fast-tracked onto the yellow section where we need to do some diagnostics. So what are the options for her? A TST, we could do that if there's no known contact. We could do a urine lamb test if she qualifies, same as what we saw in the previous patient, but in this case, she qualifies for different tests. So she certainly qualifies for a TB skin test. She does qualify for a urine lamb test because she's not on treatment and she's sick enough to be admitted. She also needs a chest x-ray. And again, she's quite sick. So, you're not going to get a spontaneous sputum off her. So you decide to do an induced sputum, and a stool would be an option in this patient as well. So why do we classify stool as a pulmonary sample? The reasoning behind that is pretty much the same as a gastric aspirate. When children have got TB, they cough, or what's in the bronchi gets coughed up to the back of the throat and is swallowed and goes into the stomach. And if it doesn't get sucked out of the stomach by a nurse who's able to do a gastric aspirate, it goes all the way down the tube and comes out the other end. So this is an option that's available. Please note that in the new NHLS guidelines, we do actually want a sample to be a stool sample with a pulmonary sample if possible, because we'd like to get the susceptibility, and that really increases the yield. And it's only available for children under 10, and they will reject your sample if it's not a child under 10. And we don't really need a lot of stool. So it's just a small, about the size of an adult's fingertip is as much as we need. They do ask us not to overfill the bottles, and a slightly harder or more firm sample is preferred, but a runny sample can also be accepted. So in this case, she's got a 7-millimeter MAN2, which because of her severe immune deficiency actually counts as a positive. So a child with a MAN2 of more than 5 who's immune suppressed would be positive. Her urine lamb test is also positive. So this child is not getting away without TB treatment, regardless of what any of the other tests show us. We know that a urine lamb test doesn't exclude you from getting a sample to be sent off. So a sample is sent for her, but there's no MTB complex detected, and her culture, of course, will take a bit of time. And unfortunately, the chest X-ray machine is now broken, so you'll have to come back next week. So I'm hoping that you can see that this child was correctly fast-tracked, that there's no doubt that even though we don't have a lab diagnosis, this child certainly needs to be started on TB treatment, and we go through the same things. In this case, We don't have a chest X-ray, so we could still look at if she's suitable for a shortened course. In this case, we're a bit stricter. You have to be HIV negative, and you have to be under the age of 8 because we can't look for cavities on your chest X-ray. So she unfortunately doesn't qualify for her 6 month for a shortened course, and she gets started on 6 months of treatment. We know that when we start her ART, we need to boost the dolutegravir, and there are a few other little things we need to do in terms of her HIV to look after her carefully. Now, on Monday, she comes back, and this is her chest X-ray. So she's been eating okay in the ward. She's sort of doing fine. She's got a few of the things that you'd expect from a child with HIV, and you're trying to get on top of those. But with this X-ray, would this change your management at all? So I hope you can see that looks like there's widespread miliary picture on that chest X-ray, and we manage miliary TB the same as TB meningitis. So even though she had no features of TBM, and we will do a lumbar puncture, but even if it's plumb normal, we will still manage this child as TBM just based on that X-ray. So we need to switch her to 4-drug treatment, but we're going to give her ethionamide. Because she's got HIV, we treat her for 9 months and not 6, and we would notify her as miliary TB. I'm not going to give you the last patients because I think we're running out of time, but I just want to highlight for kids with TBM that there's a separate dosing chart. They need much higher doses of the RIF and INH. So I'm going to stop there. I'm handing back to Karen then.
Thank you very much, Julie. Nawazi, you're welcome to, do you want to facilitate questions? There is
Yes,
one
we
question.
can, Karen. Apologies for that. I do see Dr. Subrian has her hand up. You can go ahead.
Yeah, just very quickly, good afternoon, colleagues. Thanks, Julie. You know, your sessions are always so incredibly informative. And I'm wondering if we need to schedule another, kind of follow-up where you walk through the practical ways to actually utilize that reference guide, because I see everyone is glued, even though the time is up. I'm sorry to have, perhaps we should have even have extended it to an hour and a half, but thank you so much, Julie, for that. Yeah, I just wanted to say perhaps we just need to get a special session to get you to walk through a few more case studies, because I mean, I know I personally also have been learning so much. It's making me want to go and manage pediatrics now.
Everyone should want to manage pediatrics. But I think that's fine. I'm happy to do more sessions, and I've got other cases where we go a little bit into the weeds, and it's always much more fun if people bring their own cases, and we use real cases that we can utilize. And we've got the WhatsApp groups where we try and use the principles for people's real cases on the spot to help them to make a decision. So anytime.
No, and in fact, I like that idea better, a kind of an interactive kind of workshop session that we could potentially organize. So sorry to have to stop you, but I also see Pren has a hand up. Go ahead, Pren.
Yeah, no, great. Thanks so much for all the fabulous work on this. It would be really good. I think these case studies help really bring it together. And I would suggest you do some YouTube videos on multiple case studies. You could probably add a few more, and then these can be shared very widely.
Sorry, back to you, Karen. Yeah, I totally agree with you, Pren. I think it's a fabulous idea, and Julie does it so well as well. But back to you, Karen.
Thank you, Priya. Yes, so definitely, Julie will definitely rope you in for that. And I think maybe having another session, practical session, we'd definitely be open to arrange that. Thanks for being willing, Julie. A quick question. There was a question about the IMCI chat booklet for TB. So the idea is not that the quick reference guide would completely replace the IMC guidelines, but the idea is to work with the IMCI stakeholders when there's a next update to make sure that the TB sections align. I'm not exactly sure. I'm not familiar with a chat booklet. I don't know, Sandy, Julie.
I suspect that they mean the charts. So there's like a booklet where that's printed and laminated and often is in OPDs. I suspect that's what the person is referring to. Maybe they can clarify.
Yeah, I think that it's often referred to as the IMCI chart. Yeah.
Okay, awesome. So yeah, so I think the idea would be to align all the IMCI resources to this, and we have been in discussion already with Dr. Leslie Bamford, but yeah, so definitely, but it's not there yet. I see Ruth give us a thumbs up. Okay, we are 4 minutes overdue. Priya, yes, please.
Yes, you know something? I think maybe I'm playing devil's advocate here, Karen, but throwing back to the you know your task team. But really, you know, this guide is it actually represents a significant update to pediatric TB management. And perhaps it's something we should have looked at the guidelines, but the key metrics, you know, what are the key metrics or outcomes we are hoping to see change as a result of this widespread adoption? I mean, even the shorter regimens and measuring, you know, how many kids are on the shorter regimen and versus, you know, the 6-month regimen. I'm not sure our existing, you know, data collection tools provides that, and we might have to do it via pharmacy or something, but I'm definitely thinking about that. And I am, yeah, just kind of maybe if we don't have the answer now, throwing it back to the task team to see how we could potentially, you know, start tracking this like we did for BPAL to see, you know, what percentage of all new, you know, prescriptions are the 6-month versus the 4-month, and just being able to track this. I know we could work with the data systems and innovations task team, but perhaps it's something that we need to seriously think about. Julie, I know your hand is up. I don't know if you have an answer or a solution.
Priya, I think that just one thing which I think we should be monitoring is we want to see more kids clinically diagnosed. And I think we should be aiming for 75% of children under 5 should be clinically diagnosed and not microbiologically diagnosed. All of the cases I gave today were diagnosed clinically and using the decision algorithm. The lab did not help us in any of these cases. So if we could just measure one thing, I think that's firstly because that's so different to what we expect in adults. So that's why we like to highlight it. Kids just don't give us good samples, and the lab, I mean, they're doing their best, but I think having the confidence to call it TB even though you don't have confirmation. So I think if we could push towards a higher percentage of clinically diagnosed, I think that would be a major achievement.
Actually, so Julie, but I do think it's not only high proportion, because I think even at the moment, still majority of those kids are clinically diagnosed, right? But it is actually an increase in the number of children started on treatment. And Priya, I do think though that if we could, the two key things would be that, and then how many kids are started on the shortened treatment course. And it would be definitely something that I'd love to explore with you and the data innovation task team, because it is a big problem how we currently, it's really challenging. And I had multiple conversations with Dr. Mvusi around this, but we haven't been able to come up with a solution how to collect that data within the program. So please, I think Nolwazi, if you could help us to set up a meeting, that would be amazing.
Problem, Karen. Priya, you can go ahead.
Yeah, sorry, just one last question, and I think it's something that everyone would also be interested in, is just understanding the dissemination plan, you know, for these tools now. What are the next steps? I know it's the materials are available on the TB Think Tank website, and Owazi will send an email to all our team members with the links. But in terms of the practical training, is there anything you want to share?
Oh, thanks, Priya. Yes, so the next step would also be a Knowledge Hub webinar. We're just waiting for Department of Health to send out an updated circular on the RRTB guidelines or RRTB algorithm to get a date for that. And we'll also share that date with everybody on the think tank. we actually have a couple of ideas to circulate them also through social media, using social media platforms. And translation is one of the big things that we haven't forgotten about, but we're still trying to figure out how to do that. And then one of the other things is printing also in some of the sub-districts or districts. So I know some of our Global Fund partners are trying looking at how they could leverage some of those funding to print locally or within the provincial budgets. But if anybody has a question or requires access or wants to know anything, they're very welcome to contact us. And then we'll see how we can support.
Yeah, and just to add, if anyone has anyone who's prepared to translate these materials for us, because funding is really tight at the moment, and I know it will be very useful, especially all the caregiver materials, if they were translated, or if you have some additional funding for printing as well. So thank you so much, and thank you to the fantastic team that has put all these materials together. Back to you, Karen.
Thank you, Priya. Thank you so much. Any last questions? I do think we probably need to wrap up, Nolwazi.
Yes, I do see one here. So it's up to the speakers if they're willing to answer it. It's from Kelly. It's under the Q&A chat. Would you like me to read it out, or you can see
Yes,
it, Karen?
please, because I'm on the Q&A
Okay.
chat, but I didn't see it. Okay, here it is.
Yes.
Is there a minimum age for TST? So Sandy, maybe you can also just like weigh in on that one. And would one repeat the culture in a child to get a treatment outcome of cured? That one I can answer no. The guideline requires 2 repeat cultures, but practically when should the clinician repeat it? Okay, hang on. That is a tricky one. Do you want to do the TST one so long, Sandy?
So I think the main messaging around the TST is that the TB treatment infection guidelines are really de-emphasizing the need for the TSTs. So in a clinical scenario, I think that the TB treatment decision algorithm really emphasizes that you want to be focusing on the children under 5. Yeah. So the ones that are not known with a contact and under 5.
Yeah, so it's a small group of kids that would be relevant to. So in terms of the question for the repeat culture, that is quite an interesting one because, I mean, in my experience, we typically we would have baseline specimens, but even if it was positive, if the child is clinically responding to treatment, we would not repeat the samples necessarily. And I'm not sure that the guideline recommending 2 repeat cultures. I'm going to have to go and look where that is. Sandy, did you see repeat cultures? I can't, like in our 90-page document, I'm also not always have everything at the top of my fingers, but from what I remember in terms of treatment response, we only recommended repeat samples if the child is not clinically responding to treatment. But Kelly, I'm happy to take this up with you, and I'll go and have a further read up and just check. So I don't know, Rosie, if you could put us in contact maybe afterwards with Kelly.
I will do that.
Thank you.
Thank you, Karen. And as Priya has already said, thank you to all our speakers. Thank you for your time. And thank you to our attendees. And we apologize for going over time. And just be quickly reminded that if you'd like to present on this very platform in the upcoming months, please email Ngozi TB Think Tank. And with that said, please enjoy the rest of your day. Thank you.
Thanks, everyone.
Bye.
Thank you.
Thanks,
Bye-bye.
everyone. Bye.